Chapter 28: Child, Older Adult, and Intimate Partner Violence. The objectives for this module are to identify the nature and scope of family violence and factors contributing to its occurrence, describe the risk factors for both victimization and the perpetuation of family violence, and identify three indicators: A, physical abuse; B, sexual abuse; C, neglect; and D, emotional abuse. In our first case study, a 12-year-old boy, Adam, is admitted to the ED with a broken wrist, swollen eye, and fractured radius. His parents seem very anxious, and the father seems particularly on edge. When the attending nurse asks what happened, the mother immediately says, "skateboard accident." Adam looks up at her quickly, and she smiles at him and says anxiously, "Honey, we've told you to be more careful on that thing, right?" She has tears in her eyes and avoids eye contact, raising a shaking hand to her mouth. There are many different types of abuse: physical abuse, sexual abuse, emotional abuse, neglect, and economic abuse. A crisis situation. This is any situation that puts stress on a family with a violent member. Each would include first a perpetrator, and that's any household member that's violent towards another. That would also include a vulnerable person, such as a family member upon whom the abuse is perpetrated. Other terms could be victim, survivor, being a survivor recognizing recovery in the healing process. First up would be child abuse, and it could take two different forms. One would be acts of commission, and these are deliberate and intentional. They include physical, sexual, and emotional abuse. They could also be an act of omission or neglect. This occurs when a child's basic physical, emotional, or educational needs are not met, or when a child is not protected from harm. Acts of omission include physical neglect, emotional neglect, medical and dental neglect, educational neglect, inadequate supervision, and exposure to violence. There are 2.4 million referrals for child abuse and neglect in 2018. 73% of those were neglect, 46% included physical abuse, 8% included medical neglect, 28% were younger than 3 years old, 15% less than 1 year old, 78% of deaths were in children younger than 4, and about 92% of child abuse perpetrators are the victim's parents. There are many comorbidities that go along with this. The occurrence of one type of abuse is a fairly strong predictor of the occurrence of another type. And in lifetime, it would involve secondary effects such as anxiety, depression, suicidal ideation, and PTSD. Continuing with our case study, 12-year-old Adam is taken for x-ray imaging of his forearm. The attending physician sends his parents to the waiting room, though the father is particularly reluctant to leave his son's side and becomes mildly agitated. "You can see him again soon," the physician occurs, "but not in radiology." Reluctantly, the father cooperates. "You don't have to bug the kid about his skateboarding, okay? Last thing he needs is questions. He never can think straight on a normal day when he's badgered, let alone when he's hurt. He's in a class for mildly retardeds." Alone with the nurse, the physician says quietly, "That's Dad's a little on the angry side. More tense than worried, I think. See what you can find out while I talk to the boy in radiology." The nurse agrees. There are also many risk factors, such as the child is seen as different, the child is seen as fragile, the child reminds a parent of someone they dislike, the child does not live up to a parent's fantasy, the child is the result of unwanted pregnancy, and the child whose emotional bonding was interrupted due to prematurity or prolonged illness. Characteristics of abusive parents are a history of child abuse and neglect themselves, family authoritarianism, harsh punishments, low self-esteem, social isolation, and poor coping skills, also low frustration tolerance. They could also be experiencing a crisis, have unrealistic expectations of the child, have severe mental illness or substance use disorders, and poor impulse control or violent temper. Next up will be intimate partner violence. This has an epidemiology of being 25% of women and 10% of men are being abused. Within teen dating violence, 1 in 11 are females and 1 in 15 males. Partner stalking includes 10% female and 2% male. Nearly half of married couples have instances of abuse. Same-sex relationships that have the same rates as heterosexual relationships, and 1 in 10 homicides is spousal murder. A major risk factor is, unfortunately, male perpetrators, and may believe in male dominance and the need to be in charge, and the belief that physical aggression lends power. They could also have pathological jealousy, substance or alcohol use disorder, resentment towards pregnancy or the baby, and violence that may escalate when the woman attempts more independence or attempts to leave. Within the cycle of violence, there's the tension building stage, the acute battering stage, the honeymoon stage, and repeat. These periods of calm and safety diminish over time and with repetition. And finally, older adult abuse. This is mistreatment, such as the failure to provide basic needs or the failure to protect. Also, physical or sexual abuse, financial abuse, and an epidemiology of family and custodial care personnel. The Centers for Disease Control and Prevention estimate that about 1 out of every 10 older adults older than 60 years of age who live at home are victims of abuse. This number may be far higher in that for every case reported, 5 go unreported. This lack of reporting may be due to isolation, dependency, and fear of retaliation. Further complicating the picture is that the older adult may be caring for him or herself, which creates the potential for self-neglect. Abuse occurs in both institutional and family settings, and family members are often the perpetrators in most of these incidences. Other risk factors would include poor mental or physical health, disruption due to a disorder such as Alzheimer's or Parkinson's. They are physically dependent on the perpetrator. For a female older than 75 years of age, white, living with a relative while impaired, and an elderly parents cared for by children or spouses they abused earlier in life. In our first audience response question, which might the nurse cite as the most likely indicator that the father is possibly a perpetrator? A, his description of his family's needs. B, his insistence on being the one to provide financial information. C, his disdain for skateboards. Or D, his description of his son's learning disability. And that answer here is D. He described Adam as having trouble thinking straight on a good day and being in a class for mildly retards. This may be a sign since children most at risk for abuse are perceived as different by the abuser and possibly by others. While it's true that abusers frequently control the family's finances, his providing the family's financial information is not unusual since, in most families, one parent or spouse often is a quicker source of information. He did not express a disdain for skateboards, and even so, that would not be an indication of a possible motive. The application of the nursing process. For our objectives, describe 4 areas to assess when interviewing a person who has experienced abuse. Identify 2 common emotional responses the nurse might experience when faced with a person who has been abused, and formulate 4 nursing diagnoses for the survivor of abuse, and list supporting data from that assessment. Continuing with our case study, alone with Adam, the nurse says, my little brother falls off of his skateboard a lot. What kind of board do you have? Adam looks panicky at the question for a moment, then shrugs and says, I don't know. The nurse tries again. Jason has one of those ones with a ninja painted on it. Do you have that kind? I don't know, Adam says. Maybe. During our general assessment, we would include things like a history of sexual abuse, family violence, and drug use or abuse. Also, during the interview process, we would avoid words like abuse and violence. Ask how disagreements are settled and how children are disciplined, and avoid assumptions about a person's sexual orientation. While alone for a moment with Adam's parents, which secondary question is least appropriate to ask at this time? Would that be A, how do you discipline Adam? B, who helps you take care of his special needs? C, what about Adam's behavior bothers you the most? Or D, what did you do to this child? That answer is going to be D, what did you do to this child? Making the parents feel accused or judged will not help at this point. You may scare them away and thus see your patient whisked away without getting proper help and available in a visibly volatile family situation. Instead, ask questions that may elicit more information, while also suggesting an understanding of the parents' challenges and areas in which these parents may need help. Such helpful questions include, how do you discipline your child? What about your child's behavior bothers you the most? And who helps you with your child? Your assessment should also include violence indicators, the level of anxiety and coping responses, their family coping patterns, support systems, suicide and or homicide potential, and drug and alcohol abuse. The signs of sexual abuse in children would include a sexualized behavior, a precocious sexual knowledge or explicit talk or images, or demonstrations of sexual aggression, acting out sexual interactions, masturbating molestation, sexual promiscuity in older children, PTSD symptoms, somatic complaints, and feelings of guilt. For emotional abuse, we would look at low self-esteem, reported feelings of inadequacy, anxiety and withdrawal, learning difficulties, and poor impulse control. For neglect, it would be children that appear undernourished, dirty, and poorly clothed. Inadequate medical care, such as a lack of immunizations, and untreated medical or dental conditions. There could also be economic abuse, such as a failure to provide for their needs. Assessment variables would include anxiety, coping mechanisms, support systems, suicide potential, homicide potential, and again, drug and alcohol abuse. For our assessment documentation, we want verbatim statements from the patient, including who said what and when. The body map to indicate size, color, shape, areas, and types of injuries with explanations, and physical evidence of sexual abuse when possible. Your self-assessment will include intense and overwhelming feelings, strong negative feelings that may cloud judgment and interfere with objective assessment and intervention, as well as common responses to healthcare professionals. For our discussion questions, what are some questions you should ask Adam? Ask him directly, but in a non-threatening manner, if someone close to him or her caused the injury. Tell me what happened to you. What happens when you do something wrong? Then ask specific questions such as, when was the last time it happened? How often does it happen? And in what ways are you hurt? When applying the nursing process, we want our nursing diagnoses directed towards protecting vulnerable family members and can also include perpetrator and plans of the care. For outcomes, we want to reduce or reverse the problem addressed. Other objectives would include writing out a safety plan for a victim of intimate partner abuse, discuss the legal and ethical responsibility of nurses when working with families experiencing violence, and compare and contrast the primary, secondary, and tertiary levels of prevention, giving 2 examples of intervention for each level. Other objectives would include describing at least 3 possible referrals for an abusive family, including the telephone numbers of appropriate agencies within the community, and discuss 3 therapeutic modalities useful in working with abusive families. When planning, the Joint Commission guidelines require staff education in family violence and abuse, development of standards of care to guide clinical practice, and the protocol for planning, such as the patient safety first, discussing with the patient if possible, the child to be removed to a safe place, and consider the needs of abusers as well if they are motivated. Implementation would include reporting abuse, considering the family's culture, counseling, including that safety plan for a rapid escape, case management, promotion of community support, and health teaching and health promotion. Wrapping up our case study, in the end, the nurse does suspect child abuse in Adam's case. What important documentation is needed? Other important elements is going to include findings from the initial assessment, including verbatim statements of who caused the injury and when it occurred, a body map to indicate the size, color, shape, areas, and types of injuries with their explanations, as well as any physical evidence of sexual abuse whenever possible. When preventing abuse, that's first going to be primary prevention. These are measures taken to prevent the occurrence of abuse. For secondary prevention, these are going to be those early interventions within an abusive situation to minimize their disabling or long-term effects. And tertiary prevention, facilitating the healing and rehabilitative process, providing support, and assisting survivors of violence to achieve their optimal levels of safety, health, and well-being. Just like with every other module we've had both here and MedSurg, that primary is always going to be preventing it from occurring. That secondary is going to be dealing with that acute situation actively happening, and the tertiary is recovering from that acute situation. Suppose you decide to join a team to help prevent child abuse in the community and plan to hold classes for new parents. What are some topics that should be covered? Some topics include reducing stress, reducing the influence of risk factors, increasing social supports, increasing coping skills, and increasing self-esteem. Connecting parents to appropriate resources in the community that can meet their needs is also important. Failures of interventions with abusive families often are due to problems within the social, economic, and political system in which we live. Nurses can direct their interventions to this social environment with questions such as, is corporal punishment an acceptable technique for guiding behavior in children? How do we address the unequal burden of caregiving responsibilities placed on women? Why is a low priority given to education and preparation for parenthood? And how can we change the belief that older adults have little social value? Treatment modalities would include individual therapy, family therapy, and group therapy. Adam admits, I don't have a skateboard. I didn't fall off anything else either. He agrees to tell you what happened, as long as you keep it a secret. What should the nurse do? A. Agree to keep the child's secret to build trust. B. Ask the child's parents to explain what happened. C. Explain that a nurse cannot always keep that promise. Or D. Have the child talk to another victim of child abuse. And that answer here is going to be C. The nurse has a responsibility to both protect the victim through access to appropriate agencies and to report the abuse to child care services. It's unethical and not legally possible to promise to keep a child's secret, especially in the case of suspected abuse. Asking the child's parents what happened, in this case in particular, is not likely to lead to the truth under the current circumstances, especially when it's apparent the parents are so defensive that they've been willing to lie about a non-existent skateboard. And feeling increasingly threatened, they may remove the child and even take the increased threat out of the child. Finally, having a child talk to another victim of child abuse is not going to help anything, and without a professional's presence, could do great harm. Audience response question. Child abuse perpetrators are most often A. Extended family members, B. Child care workers, C. The child's parents, or D. Strangers. That answer here is unfortunately C. The child's parents. It's estimated that about 92% of child abuse perpetrators are the victim's parents. And finally, should nurses be legally mandated to report intimate partner violence? Is that A. Yes, B. No? Those answers will vary. As we've touched on frequently in the course, your two mandatory forms of abuse to report are child and elder abuse. The thinking being that those they cannot report for themselves. While there's a lot of other horrific forms of abuse out there, those are your two legally mandated to report. That doesn't mean you can't take action either. Reporting requirements regarding intimate partner abuse vary from state to state. Nurses are legally mandated to report suspected or actual cases of child and vulnerable adult abuse. But intimate partner abuse, that is an adult, and it's going to be a very difficult situation for you as the nurse. But anyway, that's all we've got for this chapter. I'll see you in the next slides.